Moving on, next up with our PQI clinical overview is Eric Delara. Eric will speak about the PQI that he wrote on neratinib diarrhea management. Eric.
Hello. Well, thank you, Stephen and NCODA, for the opportunity to help publish this PQI and give a brief overview of neratinib or Nerlinx. The purpose of this PQI was to provide guidance on side effect prevention and management to minimize treatment interruption. Diarrhea with this drug is a very common side effect, occurring about 95% of the patients in clinical trials on the neratinib arm. The majority, 93% of the patients experience diarrhea in the first month of treatment. So there's a great need for us to get involved in the pharmacy side with the patient and staff and have close monitoring during this tough time, because it can be quite bad. Quick background on neratinib. It's indicated for the extended adjuvant treatment of adult patients with early stage HER2 overexpressed amplified breast cancer. It's to follow adjuvant Herceptin or trastuzumab based therapy. It's an irreversible tyrosine kinase inhibitor of HER1, 2, and 4, as well as EGFR, which is thought to be the mechanism of this diarrhea. Also, one quick thing, the median is about 8 days for diarrhea and lasting about 5 days, but honestly, in practice, we've kind of seen it all over the spectrum. Next slide, please. Quick overview here of the neratinib diarrhea management piece. The PQI, when I was doing this, kind of came out of our own experience with this drug. We've also built some of it into our EMR and part of our chemo teach also. We've put in the loperamide and cholesterol right into our regimen itself, so the physicians don't forget that. If hopefully we're filling it here, but if we're not, then they're not forgetting these two important medications. So for day one, the initial patient counseling, make sure the patient has the instructions and their supply of the cholesterol and loperamide. We don't want them to go out and try to get this afterwards. Advise the patients to call the office if diarrhea is uncontrolled with loperamide and cholesterol. If they have more than 4 loose stools over their baseline. So it's very important for these people to have kind of a baseline of where they're at. Neratinib should be taken with food. All 6 tablets are 240 milligrams around the same time each day. They're pretty small tablets, so it's not too bad. It's not like Zytiga or something where they're a little bit bigger. They do not want to take neratinib with any kind of PPIs or H2 blockers. If they can take, calcium carbonates or other things like that, should be within 3 hours of their neratinib. Neratinib is also a major substrate of CYP3A4, so they have to avoid grapefruit juice and other meds. So I usually kind of go over with a patient to make sure that the meds I have in our EMR also match the ones that they're taking, make sure they're not taking any over-the-counter PPIs and stuff like that, because sometimes, as you all know, patients aren't even aware they're taking them. So, and also some of our patients have had some constipation even, with these 2 drugs. So if that does happen, we've had maybe 1 or 2 patients, you can drop the Cholested and then go from there. So patient follow-up, consider follow-up 1 week after patient therapy initiation, and then bi-weekly in the following cycles as needed. Assess diarrhea. How many loose stools have you had in a given day? Just check, in your EMR that they're going to be getting a CMP. This should be done prior to start, and monthly for the first 3 months, then every 3 months is clinically indicated. We haven't had any issues on this front so far. Assess if the patient is having uncontrolled nausea or developing stomatitis. We've had a little bit of patients with some nausea. No, haven't seen any cases of stomatitis yet. And just remind them again about the PPIs and H2s, just trying to hammer that home. Next slide, please. Adjustments for toxicity. You consider discontinuing neratinib if toxicity does not recover to less than or equal to grade 1. For toxicities that result in a more than a 3-week delay, you also try to think about DCing it. And if they're unable to tolerate the lowest dose, which would be 120 milligrams, the dose reduction goes from 200 to 160 to 120. They also we put a good diarrhea grading in here. So grade 1, believe it or not, is less than 4 stools per day over baseline. So it's, you know, it's kind of a crazy thing. People look at you a little funny when you say that to them, but it's, you know, it's truth. So grade 2 is increase to 4 to 6 stools a day over baseline. Grade 3 is an increase of 7 or more. Next slide, please. All right, diarrhea interventions to discuss with everybody here. We got grade 1, grade 2, lasting less than 5 days, or grade 3 diarrhea lasting less than 2 days. You just adjust the antidiarrheal medication, fluid intake, and then when it's improved to less than or equal to grade 1 or baseline, you're doing the loperamide anyway, so you don't really have to do that piece of it. Grade 2 diarrhea lasting greater than or equal to 5 days, or grade 3 diarrhea at least lasting longer than 2 days, we interrupt treatment. So grade 1 and grade 2, you can kind of treat through without any dose adjustments. Grade 2 diarrhea lasting greater than 5 or equal to 5 days, then we do interrupt treatment until it's down to a grade 1. Then you resume. If you get into a grade 1 within a week, then you can do it at the same dose. If not, then you've got to go down to the lower dose. Reoccurring greater grade 2, then we're going to permanently discontinue. So next slide. I know I have just a tiny bit, and I'll wrap up. So I did have the opportunity to talk to our rep yesterday, who brought in these voucher cards that patients can use for the 3 different products. It does have to be a valid prescription, so your providers will have to give a prescription for this. The card works like an insurance. It's got a BIN, a PCN, all that jazz. It's good for loperamide, cholesterol, and budesonide, or Lomodal, and it's for 3 fills of each product. I was told it was not NDC specific. I have not used it yet, so we'll see. But you can only get these from your pharma rep, so you can't print them online or anything like that. You do have to get them from your rep. So next slide. I think that's it. We got the references and a little bit over. Sorry about that.
No, that's great, Eric. Thank you so much for that great discussion. And we did actually have a few similar questions come in, and it's all relating back to your incorporation of this PQI particularly or specifically into your EMR. Can you discuss that a little bit more, that process?
Yeah, so I mean, basically into our regimens within our EMR, I put in the loperamide and cholesterol as drugs. So they will show up when they create a treatment plan. Those drugs will populate, so that the nurses and medical staff will see that and say, oh, I got to write this script for these drugs. I can't forget. Just kind of a reminder.
Great. Well, thank you for clarifying, and we'll leave it open for just a few more seconds to see if any other questions come in. And as always, everyone, if you do have a question, feel free to either use the chat Q&A box or raise your hand, the raise hand function. If not now, if you have a question for Eric a little bit later on, we can always answer those right before we break for today. So again, Eric, thank you very much, and we appreciate it.